السلام عليكم زملائي الأعزاء. أنا محمد الشرقاوي، استشاري الأشعة التشخيصية والتداخلية، متخصص في المخ. بشتغل بقالي 11 سنة في ألمانيا، والنهاردة حابب أكلمكم على الانتراكرينيال thrombectomy. أنا أول intracranial thrombectomy عملتها كانت سنة 2014، وحابب هشير معاكم الاوفر فيو عن عمليه الستروك تريتمنت من ساعه ما العيان بيدخل المستشفى او يجي لنا الاون كول، يجي لك التليفون وتبقى عارف انت رايح ومستنيك ايه. To start with, I'm gonna talk about the following points: clinical symptoms, communication between the different departments, the time window you usually have to treat the patient, what I'm gonna need for the pre-interventional diagnostic, the materials and recanalization strategies, and I got some cases that I did from last year. And is it only for the middle cerebral or internal carotid and basilar arteries? And at last, the take-home points. So to start with, clinical symptoms, stroke is mainly the new, or it's not just what the patient is got a hemiplegia, how the motor function is, but you have to score it. We always get from the neurologists NIHS score. This is the National Institute of Health Stroke Scale, and it's usually composed of 11 items. In each item you have a score between 0 and 4, and so the neurologist examines the patient, tell you he's got like 10 or 15, then you're speaking about a moderate stroke. If he's got 1 to 4 points, you're talking about a minor stroke, and above 20, that's a severe stroke. If you're the one in the hospital and you're the resident, you're gonna tell your colleague at home or is an on-call, you have to tell him about the onset, when it did begin, if you know it, or it's a wake-up or unknown, what exactly the symptoms are, what NIHS scores the patient have, and of course tell him about the CT and MRI findings. It's always good to know how it looks like before going directly to the intervention, so you have to see the CT yourself before doing the intervention. If you're the one sitting in the hospital and you don't know or you're not sure, you have to consult a colleague per teleradiology. This is available today, and ideally time window, the sooner the better, but collaterals from the external carotid arteries or from other territories, or like the posterior cerebral for MCA or anterior cerebral, can get you extra time. It's not just a decision from the picture, so you have to consider all the factors, and it's an interdisciplinary decision with your colleagues from the neurology. To begin with the thrombolysis, I would suggest this directly after CT. The patient still on the table, you start to infuse the RTPA, and the neurologist always come with his kit, so it's almost done in the first 5 minutes after CT. In that time, the anesthetist is informed, and you tell him we are going to the angiography. Of course, you need a general anesthesia. Some colleagues do it without, or just with sedation. That's really difficult, especially if you're going for a M2 or M3 segment. If the patient being referred from another hospital, you have to consider doing a second CT or a second picture to see what did happen in that time, especially if he arrives late. We're talking about time for more than 2 hours between two hospitals. If the patient undergoes thrombolysis at that time and he gets better, then you do a CT, maybe you have no thrombosis anymore, or the patient gets worse and you must do a CT to rule out an intracranial bleeding. Your colleague from the neurology will also organize a bed in the ICU or stroke unit. That's how you do it. And then speaking about the time window, as I said, it's ideal 0 to 6 hours, but in the real life, it can really get longer. And as I said, collaterals can get you extra time. If you have discrepancy between the clinical picture you have, NIH score you have, and the infarct you see, and you still have a thrombosed vessel, in these patients, they really benefit from an intracranial thrombectomy, and this was shown by the Dawn trial in the New England Journal. So, materials and recanalization strategies, I usually use a short sheath, 8 French, and through it I get a balloon-guided caster, or you can also use a long sheath, 6 to 8 French, usually 90 centimeter long. Depending on the aortic arch, you have to use a vertebral caster, or if it's really elongated and you're getting to the left common carotid, then you have to use a sidewinder catheter. Balloon-guided caster or aspiration, you can do whatever you feel comfortable with. I used to do the safe technique a lot. The advantage of safe technique, you have a caster directly in the middle cerebral artery, and you start suction with a pump, with a vacuum pump, and you get your stent retriever with a thrombus, and you take both out through the sheath. With a balloon-guided caster, the advantage, you have 2 casters, just a microcaster and the balloon, and with the balloon you can block the flow during the whole procedure of stent retrieval. It's like 1 minute or maybe less, and then you stop the flow and you don't lose your clot. A very interesting internet site is One Stop and Stroke. You can find these explanations and maybe some videos. And you have to be very flexible when doing this thrombectomy. You have to be able to change your strategy during the recanalization, and you have to consider intracranial stenting or stenting of the internal carotid at origin if it's necessary. I don't give intravenous heparin before the procedure or after getting the sheath in. I usually do it with heparinized saline for the casters, and nimodipine also to avoid any vasospasms. And I always use a closure device. A closure device can save you a lot of headache after the procedures, that the patient doesn't get a pseudoaneurysm or something from that sort. So that's how my table looks like, and I start to prepare my table while the anesthetist is doing his work. So I flush every caster and I connect my things outside. You see here the connections and my Terumo guide wire. I have here a vertebral caster inside the balloon guided caster. I already have a sidewinder in this case because it was a left common carotid with some elongation. And when we go to the angiography suite, we are usually 2 on table. So the one gets things prepared regarding flushing the casters and gets all air bubbles outside of your infusion, and the other start getting the access. So I would like to share some cases from my daily routine and how we really get it in real life and how we do it. The first case is a patient who was 60 years old. He has an NIHS score from 14, and it was a wake-up stroke. So as you see here on the left side, this is a flare, T2 flare, and I don't see any infarct, edema. In the diffusion weighted image, you see in the insular ribbon acute infarct, and if you look to the top MR angiography, you have no flow in the internal carotid artery on the left side. This patient already had a thrombolysis IV during the transport from the other hospital, and we went to the angiography suite. Here is a first picture, and you see it's a left side on the lateral view. I usually do it one for the aortic arch, this one, and carotid. And as you see here in the common carotid, you have a stump and nothing else. You see only the external carotid artery branches. We passed this thrombosed vessel with a Terumo guide wire, and after that we got through our balloon guided caster, a microcaster. We always do an injection over the microcaster to be sure that you are still inside the middle cerebral artery branch, M2 segment, for example. And in this case, you see here a very high grade stenosis in the internal carotid artery. Here's some kinking, but not really a stenosis, but this is the real one. So we dilated this before to get our balloon guided caster through. I always put the balloon guided caster at the skull base. And as you see here, after the first stent retrieval maneuver, we have flow again in the middle cerebral artery and internal carotid. The internal carotid is fully open, and the middle cerebral artery is also open. But if you look in the lateral view, you have a still thrombosed M2 segment. So we are not finished yet. We did the second trial, and we got our micro guide wires through the thrombosed vessel. In this case, it was Traxis. This is my standard wire. And we did a second stent retrieval maneuver, and here you see the full middle cerebral artery branches. And in the last late venous phase, you see it's still in this branch, but it's very good collateralized. So we will leave it like this. We don't have to go too far. You can sure make a perforation if you try to get very distal. Are we finished now? I guess not, because as we know, we had a proximal stenosis. We took a look at the proximal stenosis after doing everything intracranially, and we stented this lesion with a 7x30 carotid wall stent. You see it's a very good open, and it reaches to the common carotid, and this is how you have to do it. If you have a vascular surgeon who can do thumb end arterectomy, it has a benefit that the patient doesn't have to have a dual antiplatelet. I usually give aspirin 500 milligram during stent implantation, and this is the final result. You have to do a run before the closure device to get sure that during the stent implantation you didn't distally embolize anything. And you have to record the result in the system. It was an MTK2C because of this branch, but actually it's a very good result. And the follow-up is usually on the next day. And on the next day, we see non-enhanced CT. You have infarct demarcation in the insular ribbon. You have also a little bit in the temporal area. and you don't have any in the parietal loop. That's a very good result. You can also do a dual energy CT to rule out or to differentiate between blood and contrast media extravasation. After GCT, we usually begin with a loading dose, clopidogrel. It's 300 milligram, and aspirin, of course, 100. We do it for 4 weeks, and then we give aspirin 100 milligram per day, lifelong. Second case, it was a 92 years old lady. She was found from the neighbors. Unknown time window. It was an NIHS from 17, so it's a severe one with a Glasgow Coma Scale 7. And as you see here in the non-enhanced CT, you have a hyperdense artery sign. And if you look in the sagittal view, you have here the thrombus in the tip of the basilar artery. It's clear. We were not sure if we do it or not, but the relatives they wanted that we do it, so we went for it. And the patient has in the CT angiography a bicarotid trunk, as you see here, the left carotid, and here the right carotid. It's a bicarotid trunk, and if you look further, you see it's a very elongated vessel. The subclavian goes first a loop downwards and gets back upwards. So this is how it looks in the angiography. Here's a bicarotid trunk. Here's the right side, right common carotid, and in this case, we want to go to the subclavian. I got the sidewinder caster. You see the tip of it here, and it's a very, very tough loop that you go up and down and up again. So I tried for like 5 minutes. It didn't work. So I was ready, and I thought it would be better to do it transbrachially, and that's what I did. So doing it transbrachially, this is the first run. Here, if you can see that the basilar tip is not there. We have another anatomical variant in the lateral view. That's a primitive trigeminal artery. It's not the posterior communicating because it's not on the distal top. And I decided just to do it with an intermediate caster aspiration. So I advanced my Sophia 5 French caster and did aspiration. And that was the result. After aspiration, the basilar tip is back again, and it looks angiographically very good, but the patient didn't benefit because it was, as I said, unknown time window, and it was really late. A third case, this is also a very difficult one because we got it from another hospital, patient COVID positive, and he was extubated. And after the extubation, the doctor's talking to him, he's hemiplegic. We don't know when it did really begin. We see already infarction in the basal ganglia and corona radiata. So I didn't know what to do, but I said, okay, if it's a moderate stroke, moderate to severe, 15 NIHS score. So that's how it looked in the perfusion CT. And here you see in the time to drain per long time, there is a little bit mismatch between blood flow and blood volume. And as I took him to the angiography, that was the first picture. You can see here in the side view, this is the posterior communicating artery with the posterior cerebral artery, and you don't see anything here. So I passed through the thrombosed M1 segment with my microcaster, and I did a picture with a preset stent retriever 6mm by 50, and you can see it's also not that too much flow. It looks really weird, and it felt a little bit hard passing through this thrombosed part of the middle cerebral artery. So I performed stent retrieval thrombectomy, and I didn't really get any thrombus out. So I decided to go more aggressively, and I did like 4 maneuvers with a GESR-7 catheter plus preset. The GESR-7 is the biggest thing we got on the market, and a preset also, and that was the results after 4 times aspiration, and I still didn't see any real thrombus in the vacuum pump or in the stent retriever. So I waited for like 3 minutes, and then 5 minutes, and I did another run, and it gets closed again. You see here, and after 3 minutes, it's looked like it's a very high grade stenosis of the M1 segment, causing this thrombosis of the vessel. So, and at this point, I was not really sure, should I stent it, should I do a PTA, or should I do nothing? So I decided to look to the other vessels, because I think it's a heart thrombose thing, it's stenotic, it must be collateralized. And I thought about this non-enhanced CT, and I don't see a very big infarct that I've been expecting for an M1 segment. And as I injected it from the left side, you see very nicely the collaterals from the other side, and you also see the collaterals from the posterior circulation. And at this point, I decided not to do intracranial stenting, because the patient has already an infarct, and I don't think it's gonna get worse. It's already worse or bad, so I didn't do it. The 4th case was a 56 years old male. He came to us with an NIHS 15 to 20, and he had a hemiparesis and aphasia. As you see on the native CT, you have here a hyperdense middle cerebral artery sign, and in the CTA, in the foramen lastrum on the left side, you don't have a contrast media. On the right side, you have contrast, but on the left, not. And you see once again here the thrombosis in the middle cerebral artery on the left side. This was his pictures from the perfusion, and it's not really a mismatch, but I don't have infarction in the native CT. At this point, I decided to work on the native CT and do it, because the patient is 56 years old, and I can't just let him with this stroke. So we spoke to the colleagues and we did it. I took him to the angiography suite, and he also had an internal carotid here, also thrombosed at the beginning, and I passed it. And here's a confirmation that it's still intraluminal. The middle cerebral artery is contrasted. And this was after the first maneuver of thrombectomy. You still see here maybe thrombosed part, and here in the cavernous segment, it doesn't really look well. So I performed another run with stent retriever in place, and I did another thrombectomy. It gets better. It gets better from the flow, and I did a oblique views, and at this point I see the problem. What really causes the whole thrombosis, and it was this high-grade stenosis. And at this point, you can just let this high-grade stenosis without PTA and stenting. So I passed through the stenotic segment with a micro guide wire again. And I dilated with a neurospeed balloon. It's a 3x8 millimeter. And I do this always with a manometer. It's I don't do it with a hand syringe or something like that intracranially. And after that, it gets better. You still see there's a rest. So I decided I will implant a cradle stent. It's a high radial force, 4x20. And it really fitted very good in this segment. And at this moment, after or during stent implantation, I asked the anesthetist to give a bolus of integraline. So, it's according to weight, and also integraline perfuser till the next day. And the final result for the stent looks like this, and it looks much better than it was. And to look at the final results from the whole thrombectomy, you have again the middle cerebral artery, the branches are contrasted, so it's a very good result. CT on the next day, of course, we expect to see infarct demarcation, and in this case we saw it also. You can see it temporal lobe and here, and this was for that case. And one more case with a 38 years old male patient. This was last week, just at the beginning of the day. And here is like the hyperdense media artery, like really in the books. And here you see in the CTA, it's thrombosed M1 segment. Do I need a perfusion CT? No, because I have onset 1 hour ago. I don't need it, and I didn't do it. And the NIHS score was more than 10, 38 years old. No, you don't have to do it. We started the thrombolysis on the way to the angiography suite, and in the angiography suite, it looked like this. We had our balloon-guided catheter. We have here the M1 thrombosis, and you see it very nicely in the lateral view that there's nothing. And this was after one stent retrieval maneuver. So we moved the thrombus a little bit, but we didn't get it out. And we have here the balloon guided catheter in the left internal carotid. So he's a young patient. We decided to do it more aggressively, and we got 2 stent retrievers in the M2 branches, one in this branch and one in the frontal branch. And here you can see it again, the 2 branches of the middle cerebral artery. And that was our final result. We got it back perfused, and this is how it looked in the late phase. So CT on the next day, the patient has infarct demarcation in the basal ganglia, but clinically he really profited from the intervention. He dropped to NIHS 2, and this is really helpful for him. So another case number 6, it was a 82-year-old female. She had a hemiparesis, dysarthria, dizziness, and NIHS score 5. So in the native city, I don't really see any infarct demarcation here in the brainstem or in cerebellum. And if you're looking to the CTA, you have here the basilar artery is contrasted. Here is the vertebral artery on the right side. On the left side, a little bit hypoplastic. And on the right side, if you look proximally, it looks like very atherosclerotic. Of course, this patient had a perfusion deficit in the time to drain, but she has no basilar artery thrombosis. It's mainly the problem from the right vertebral artery. It was 4 a.m. as I got the call, and I said, okay, if it's getting better, from thrombolysis, and she has no basilar artery thrombosis, so we don't have to do it. And I thought, okay, it's good. I called my colleagues and neurologists around 12. He said, yeah, she is getting better. She's almost have NIHS from 2 or something from that source. So I said, it's okay. But 18 hours later, the patient is deteriorating rapidly, and we did the CT again, and she has a basilar artery thrombosis. So if you see here in the basilar tip, it's thrombosis in the very last distal part. As I knew, I took her directly to the angiography. We didn't do any perfusion again because it's now I don't need it. I know already that she was a little bit at a deficit. The right side doesn't look really well. Here you can see it's a very thin V2 segment of the vertebral artery, and then it gets back normal here. But I didn't really get my sheath inside the vertebral artery. So I decided to take a look to the left side. And if you see here, the left vertebral artery is okay, but the main problem was a V4 segment. It's very thin. I cannot get a 5 millimeter stent retriever through it. And if I did it and I had any complication, so I missed the left side, and maybe that's the side that she needs after the thrombectomy. So I decided to get back again to the right side, and I did a PTA to get my sheath inside, but I couldn't get the sheath inside. So I decided at that point to get a second wire to remove in the left vertebral artery to have more support. So it really helped. And I punctured the left femoral and got the second catheter in the left vertebral artery to do my controls because I cannot see anything from the right side. So this picture was over the microcatheter I got in the basilar artery. In the lateral view, you see here the thrombosis in the distal tip of the basilar artery. So I passed it and I did a one maneuver, and I was lucky. It was really a one maneuver on the right side with a Terumo wire inside the vertebral artery and the micro guide wire and stent retriever afterwards to get it recanalized, and it was recanalized, but the right vertebral artery is still not good, but I didn't do it. And I did my control from the left side to see that open back again. And in this case, I didn't even try to recanalize the right vertebral artery because it's a long segment, because I maybe have to stent it, and I cannot take this risk. So that was the daily routine we have in the angiography suite. And now I want to some insights about other arteries. It's not just MCA, ICA, or basilar artery. You can also do a thrombectomy for the posterior cerebral artery or anterior cerebral also. And here's a publication about the posterior cerebral artery. I guess they had a from multi-center study with 243 patients, and they did for P2 and P3 segment. It's a rare thing. I know I performed it maybe 3 or 4 times from 100 thrombectomies if you are counting. So it's not that often in the daily routine, but I got one case here to show, and this was a patient with aphasia and arm paresis, NIHS 8. You see on the native CT here the hyperdense artery sign. You don't see infarct demarcation, and in the perfusion CT, you have the mismatch between blood flow and blood volume, and you have the prolonged time to drain. So we decided to do it. We got him in the angiography suite. Here again, back over the right vertebral artery, I got my sheath just before the origin of the right vertebral artery, and then intubating the left posterior cerebral artery with a micro guide wire and microcaster, doing 2 passes, and after 2 passes, I got it back recanalized. The CT on the next day, it showed a little bit infarct demarcation in the lateral thalamus, but in the posterior cerebral territory, it was actually okay. And at last, but not least, my take-home points for stroke treatment. You have to have a standard stroke protocol at your department. This is a must. CT and CTA as well as aspect score is totally okay. You can perform CT perfusion if you train your colleagues and the staff you have, so that it doesn't cost you a lot of time, because most of the time you can do it just from the native CT and the CT angiography. If you get pictures or investigations from referring hospitals, get the best out of it. Speak to the doctors yourself, know the symptoms, know the onset. Try to organize everything with your colleagues from the neurology and anesthesia to achieve the best workflow at your department and optimize the outcomes. Don't forget to know the exact anatomy before you get on table, because you can get to chaos if you don't know really the anatomy. Get your table material prepared while the patient getting intubated or before it. You know, time is brain. Good collaterals buy you extra time. And be flexible to change your strategies in recanalization if you don't get success with a strategy you're using at the moment. And document your steps of the procedure, your MTK results, and your recommendation for anticoagulation and anti-aggregation. Get feedback from your colleagues and work in team to have better outcomes for your patients. Thank you for your attention. Any questions?